Okay, take it away.
Okay, perfect. Thanks, everybody. Thanks for having me back. Um, just kind of by way of background, I'm a physician, emergency physician down in Kingston, and do some work in the Waha area as well. So certainly not as familiar with the nursing stations as you guys all are, but have done a fair bit of calls out of there. So I really just wanted to take today just to kind of do a bit of an overview of chest pain. Oops, my mouse is not working. There we go. And again, just kind of looking at like a high level approach. Feel free to, I know it's hard on the Zoom format, but feel free to throw comments in the chat. I should be able to pull that up. And like possibly if there's any questions or if something isn't clear, just feel free to unmute and ask away. So today is really to kind of look at just an overview of an approach to chest pain, the differential diagnosis, important things in the history and physical. And then we'll kind of review a few of the more acute presentations and then go through some cases. And certainly out of the nursing stations, I understand that there's limited resources, and so you may not actually come up with a final diagnosis for a patient with chest pain. But I think from my experience, um, getting patients out from the nursing station, either both with Orange that I work with or when I'm in Waha, the people that are at the bedside of the patient, up in the nursing stations, you guys really are the key. I can't look at the patient. I can't really talk to the patient in most cases. And so kind of your differential diagnosis is going to help figure out what questions you're going to ask, what exams you're going to do. And that information is like super key to getting the patient the right care. So super important. So feel free to either chat amongst yourself. Please feel free to unmute and chat. I know it's sometimes hard in the group format that you guys are in, but think about some things that are on your life-threatening, can't miss diagnosis for chest pain. And feel free to post them in the chat as well. Yep, so I've got aortic dissection, perfect. MI, cardiac tamponade, PE, Borehave, aortic dissection, perfect. So lots of differentials there. That's great, thanks. Well, I kind of tend to think of them in kind of three different ways: the like terrible can't miss, the bad, and then the, it would be nice to get the diagnosis, but won't kill the patient if you don't get it. And so essentially these are like the absolutely can't miss diagnosis, things to think about, or I think about when I'm in the emerge with every patient. And some of them can be ruled out just based on the history, or very minimized, I guess, based on the history and the exam, and obviously sometimes need investigations. But key ones for cardiovascular, so obviously, STEMI, non-STEMI, things like that. Aortic dissection that somebody mentioned. Cardiac tamponade is another one. In terms of lung things, so really PE, tension pneumothorax, and for GI, esophageal rupture can be quite devastating. And then I kind of think about the middle box of like important differentials. That includes things, so unstable angina, coronary spasm, pericarditis or myocarditis can make people quite sick. For pulmonary pneumothorax, so again, tension pneumothorax is a like gotta figure it out in a few minutes thing. Pneumothorax is kind of obviously a bit more in the middle. Medius teninus, often see this in patients who have had like forceful vomiting or like forceful inhalation, I guess. So I've seen this in a few people that were either vomiting like crazy or like sniffing cocaine. I've seen a few people with it as well. And then kind of looking at GI stuff, it's really your causes of kind of upper abdominal pain. So esophageal tear, cholecystitis, pancreatitis can all kind of present sometimes as chest pain. And then kind of thinking about more the less urgent causes. So again, cardiovascular disease, valvular heart disease can do it, hypertrophic cardiomyopathy. Pneumonia, and then, tumors, pneumomediastinum, pleuritis. In terms of GI things, certainly, esophageal spasm often presents with chest pain. GERD or reflux can, peptic ulcer or biliary colic. I'm hoping the microphone is not picking up the drilling that is going on in the room above me. So in terms of, continuing on with that, so MSK, costochondritis, muscle strain, rib fracture is certainly quite painful. Kind of the non-specific chest wall pain, things to really look for on your exam. So herpes zoster obviously can cause chest pain depending on the distribution. A nerve root compression can as well. And some patients, it is more of a psychological cause. Again, these are kind of the less urgent causes. The more important things should really be ruled out before you land on this as a differential. And certainly on if your differential is kind of more of a psychological aspect, should be really after other things have been ruled out. I'm just going to take a quick pause. Are you guys able to hear okay? Because it's quite noisy above me.
Yeah, there's no issues with our sound.
Okay, perfect. It's just me that has to listen to the drilling then. So again, this is kind of a recap just of the things we've talked about. So tons of things, but the most important things to have in your mind are kind of those critical key diagnoses. All right, so in terms of things you're going to think of for history, again, this is partly based on the differential that you kind of have in the back of your mind. So in terms of pain, location, radiation, what does it feel like? Is it sharp? Is it heavy? Is it constant or intermittent? Kind of how long did it last? Is there any pattern to it if it comes and goes? Is it similar to previous chest pain? And I will say, just because it is or isn't like someone's MI previous presentation doesn't necessarily clinch the diagnosis. But some people who present atypically with their STEMI or non-STEMI chest pain, that's how they represent. So just a good thing to think about. And then really, is there anything that kind of makes the chest pain worse, makes it better? Is it positional? Is it related to food? The other things to ask about. So, is there shortness of breath with it, nausea, vomiting, diaphoresis? Were they feeling lightheaded, syncopal or pre-syncopal? And then again, kind of thinking about some specific questions that will help narrow down that differential. So for pneumonia, do they have a fever? Do they have a cough? Do they start off with URTI symptoms? For PE, are they having pleuritic sounding chest pain? So it's, hurting all the time with all of their breathing. Are they short of breath? Do they have risk factors? And we'll talk about that a little bit more. And then more for aortic dissection. For that, I tend to think about it as like chest pain plus something. Aortic dissection is actually a fairly difficult diagnosis in terms of the breadth of how patients present, but kind of the classic ones tend to have chest pain plus something else. So neck pain, neurological symptoms, depending on how the dissection has gone up or down. Motor symptoms like limb weakness and things like that. And then for the classic presentation, some of that is really things such as like, sharp chest pain, ripping chest pain, goes straight into their back, that type of thing. And then just kind of focusing on a little bit more on ACS, there's the traditional risk factors that we all learn about. So hypertension, diabetes, family history, really of, parents having an MI at age less than 60, smoking, and obviously older age, you're higher risk. Non-traditional risk factors, just things to think about. So there certainly are some not completely understood, but ethnicity, which includes our Indigenous patients. And again, a lot of this is really multifaceted and we haven't really teased out exactly why, but it includes things obviously such as access to healthcare, diet, communities that typically have higher rates of diabetes and smoking. And then obviously there's a genetic component in there as well. Pregnancy can be a risk factor, especially for like spontaneous coronary artery dissection, which I'll mention really briefly later. Diabetes, definitely. HIV, both from the pathological process of HIV itself, but as well as from some of the medications that are used to treat it. Lupus as well. And then we see a fair number of patients kind of with stimulant drug use. Cocaine in particular is quite bad cardiac wise. And you can see like coronary artery spasm with them, but they also just get like worsening cardiac disease and atherosclerosis as well. So they're a pretty high risk population, and are often higher risk at a much younger age than we think of for like traditional ACS factors. And then kind of importantly to think about is the, chest pain equivalents. These tend to be more common, certainly in females, in older patients, patients with diabetes, patients that have had a stroke or heart failure. They just tend to present a little bit more atypically. And so some of the important things to think about for these, a patient with dyspnea, weakness, like unusually fatigued, if they're sweating or dizzy, or epigastric or abdominal pain. And then kind of going through your, physical exam once you've done your history. So, a good head to toe is always important to pick up other things. Focusing on the cardiovascular system, certainly listening to heart sounds. Is there a murmur? Is there a rub? Things like that. Actually looking at the chest wall. Again, looking for things like, rash. Is this actually an external to the heart cause of chest pain? And, do they have herpes rash or something? And then, doing an extremity exam. So, do they have leg edema? Are their pulses present and equal? Do they have any weakness? Things like that. And then in terms of respiratory system, so again, listening to their chest, do they have air entry? Are there any crackles? Are they wheezy? Do they sound like they have pneumonia with some consolidation? In terms of GI system, a lot of this is more on history, but, do they have nausea and vomiting? Are they vomiting in front of you? Do they have any abdominal pain? And then, investigations, again, are limited and somewhat different between all the different nursing stations. But, you certainly are going to want to get a 12-lead ECG, chest X-ray. I know some of the nursing stations have, but not many. If there happens to be ultrasound there and you're trained to use it, that also can be super helpful. And then blood work, so really, basic lab work, cardiac troponin. I know most of the nursing stations don't have LFTs, but again, that was thinking of something that, perhaps would get, if blood work gets sent out, you could do that. And again, not in all patients. This is kind of like narrowing it down based on your story. So LFTs, D-dimer if you're thinking PE. And then obviously, patients have to go out if they need, advanced imaging. So I'll say this is not going to be a lecture on ECG interpretation. It certainly is like a more detailed, longer lecture to go through that. I will say that the kind of traditional teaching of STEMI has kind of shifted a little bit more to like acute myocardial occlusion in terms of that. And there's a few different kind of newer resources that were helpful. If you're interested in kind of brushing up on your ECG, there's tons of online resources and courses and things like that. So, but anyways, hopefully this one is fairly obvious that it is a STEMI. And the key for STEMI treatment is really about reperfusion, which is challenging for all of our patients in Canada who are in rural or even more remote areas, obviously. Patients have the best outcome if they get reperfusion strategy as soon as possible, but certainly, within the first 12 hours, which is challenging in a lot of places in terms of like logistically getting patients out into somewhere that can do that reperfusion. Primary PCI is not going to be available to most patients in rural areas in the time frame, but it's your first choice if you happen to be able to get somebody out to a cath center within 2 hours. Within 2 hours of when they presented. And again, it kind of shows the best benefits if it's done within 12 hours. Thrombolytics are kind of a lot more common in our rural areas, just based on timing again and availability. And so, if a patient comes in, ideally, you're going to want to go through kind of the indications for and against it. And ideally needs to be given within 30 minutes of the patient arriving to the hospital. I don't imagine many of the nursing stations have it, but something to think about if there's, an intermediate step versus trying to get a patient from, X to like down to the academic center that has that can do PCI. If there's somewhere in between that's a lot closer that would be able to get them thrombolytics, then that would be an important consideration. And the patients typically go for angiogram after they have TNK for reperfusion. This doesn't have to be as urgent if the TNK has worked and they're chest pain free and their ECG has gone back to normal. They're typically kind of sent down within a day or two for cath, just to kind of help fix things and see what's going on in terms of all of the different vessels. But if a patient doesn't reperfuse with that, so they're still having chest pain or they're still having ST changes, then it's more urgent to get them down. Lots of adjuncts, aspirin 160 milligrams, 180 milligrams or 182, depending on what formulations you have. Kind of chewed and swallowed, we all know is like the first line treatment. If they were brought in by EMS, then they should have already had that, but always worth checking. And that it really is one of the most timely things that needs to get done. Other things, obviously, that you can do while you're waiting to transfer the patient out. And again, these just tend to be a bit regional as to which medications they prefer, but either ticagrelor or Plavix. And then some places do heparin bolus and infusion. I find most of the community sites either do enoxaparin or some other low molecular weight heparin because it's just so much easier than putting them on a heparin bolus. So, and then the infusion part of it. These patients are actually really high risk. So patients with STEMI in particular are really high risk to deteriorate into VT and VF just because the myocardium is quite irritable. And so there's actually been a few pre-hospital studies that show like all of these STEMI patients, if you put defib pads on them and obviously connect it up to the defib right away, should they go into VT and VF, it's actually a significant time savings in the fact that you already have the pads on the patient. You can imagine one, recognition, but then you've got to like get the pads, get them out of the package, put them on, all of that stuff really just delays the time to the first shock. So the EMS services all have a policy that anyone with a STEMI should have defib pads on at all times. And so if you have the ability to do that, that would be perfect in the nursing station, and that should get continued for the transfer as well. Oxygen, there's kind of continues to be updated evidence on, but we know that too much oxygen is actually bad. And so we're really aiming for SATs to kind of be over like 90 and over. They don't have to be 100%. In terms of pain control, nitroglycerin is an option. I would say always should have an IV in first just in case they drop their blood pressure with it. And we tend to be a bit more worried in patients with a right ventricular infarct, although the evidence behind that is actually a bit mixed and not as clear as we thought. Important thing to think about is, the actual treatment of the pain isn't, or the nitro in particular, isn't like a life-saving intervention. It's not going to make the MI any better. It's going to make the patient more comfortable. So, if the patient's really hypotensive and, you're a bit leery about giving them nitro, that's something to think about. Like, this isn't the treatment for the MI. It's really just to help their symptoms. Obviously, someone who's in pain is going to drive up how much oxygen their heart is using. So there's a bit of a fine balance there. And then certainly looking at analgesia, again, there's like newer studies that are a bit controversial in terms of maybe we don't know the best drug. Morphine and fentanyl obviously can both drop the blood pressure. And there's some kind of mixed evidence that they actually interfere with some of the antiplatelet medications. But again, it's a bit of a balance. It's easy to say, try not to give them when your patient's 15 minutes from the cath lab. It's quite different if your patient's a day or two from the cath lab. Sorry, just look at the comments. Perfect. Right. So most of the nursing stations have some kind of thrombolytic then?
Yes, they do.
Okay, perfect. Great. Yeah, and I don't know how your kits are. The kits that we have in most of the places, and certainly that we have on Orange, we really just have like a printed checklist and run through the indications and contraindications. It's not something really anybody does very often. So we're kind of worth having some kind of reference there. So hopefully your kits include that. And then kind of looking more at, so non-STEMI, obviously there's no ST elevation, but there is a positive troponin. Again, we're treating these patients with aspirin, ticagrelor or Plavix, and some form of either heparin or low molecular weight heparin. Again, certainly with these patients, can think about, oxygen, nitro, and analgesia as well. And these are patients that need to get out to go to a cath lab to have angio done, but obviously aren't quite as high risk as the patients who do have a STEMI. I'm going to just briefly mention something called SCAD. So it's spontaneous coronary artery dissection. It's not a diagnosis that you're going to make. We certainly can't make it in the emerge. It's not something you're going to make in the nursing station. But I think it is just good to know that it exists. And I'll tell you why in a second. But basically it's when, the coronary artery walls dissect, you get like a clot essentially within them. And that's going to, if it goes into the artery, it's basically just going to narrow down the amount of blood flow that's getting through. And so that it's really the clot within the vessel wall that's going to cause your decreased blood flow and your myocardial ischemia. I really just mention it more so you think about it, because this tends to happen in patients who are much younger, so kind of classically 30 to 50s. And I think a lot of people, when they hear it's a 30-year-old with chest pain, aren't at all thinking MI or anything like that. So still important to, do a good history, physical exam, and get an ECG on these patients. It's not something that's super common. It's like 3%, I think, of patients who present with ACS syndrome, but is more common in that younger population. Risk factors, female, childbirth, anybody who's doing like extreme physical exertion or Valsalva, which obviously are doing childbirth. Patients with the blood vessel inflammation. So some of that is like your, or connective tissue diseases. Fibromuscular dysplasia, again, not super common, but are at much higher risk. And this is also one of the things that we see with patients that are using sympathomimetic drugs. Is there a bit higher risk for this, as well as like classic kind of STEMI or NSTEMI? And then kind of on our less critical, but, still sick diagnosis, really is just unstable angina. So, it would be patients with a negative trope, not any ST elevation on their ECG. And these patients classically have, angina, chest pain at rest that kind of tends to last more than 20 minutes. It's new onsets, that limits their kind of activity in terms of like walking around and things like that. Or somebody who's known to have angina that's now getting like increased frequency, increased duration, increased severity. And these patients, again, need to go out for angiogram. They're not the, STEMI patients that you're trying to get out like absolutely as soon as possible, but should go out for cardio assessment and an angiogram. Again, for them, when they came in with their chest pain, you would have given them aspirin. These patients are often put on some anticoagulation until they get down to a cath lab and get their cath. Any questions on those? Feel free to pop anything in the chat or unmute. I'll pause for a second. All right, and then kind of moving on now to pulmonary embolism. So again, you want to think about it in your patients with dyspnea, chest pain, classically more pleuritic. Patients with risk factors, so prior DVT or prior PE, or look like they have a DVT right now. Patients with a history of cancer, immobilization, patients on hormones is important to think about. And then your, kind of critically unwell patient who's having some chest pain and shortness of breath, it should be on your differential. It's quite hard to figure things out in someone who's that unwell. Is it a heart attack? Are they just in respiratory failure for other reasons? Do they have a PE? But it's certainly something to think about anyways. And so I'm sure some of you are probably like, why are we talking about PE when there's no way? I don't have a CAT scan where I work, can't diagnose it, which is a fair point. Part of kind of the reason that I mentioned it is obviously it's an important differential. And some of it is just really being able to risk stratify your patients because you don't have access to it. Patients that don't have a PE, it would be ideal, not to have to send them out of the nursing stations down somewhere to get a D-dimer and a CAT scan. And importantly, in patients that we think might have a PE, important to send them out. So just kind of as an example, so, and we see this fairly often this time of year, but, a 20-year-old with, upper respiratory tract infection who comes in, they've Googled chest pain when I breathe, and now they're convinced they have a PE. So for this patient, we'll say that they're 20 years old, they've had a cough, chest pain is really just when they're coughing. They've been febrile, their heart rate's 92, they're satting 96% on room air. There's a couple of different scoring systems that we use. And so the Wells criteria is really used to determine if someone is low or high risk. If any of you have any of the decision rules apps or MD Calc or something like that on your phone, these are both in there. Don't try and memorize these, but they're just kind of important things to think about. So if we were to take, the 20-year-old whose vitals are essentially relatively normal and look at him on the Wells criteria, we'll say you did your full exam. He doesn't have any signs and symptoms of DVT. Is PE your number one diagnosis? And this is the one that's a little bit subjective. His heart rate isn't over 100. He's been up and around, hasn't had any surgery. He's not immobilized. He's never had a PE or DVT before. He doesn't have any hemoptysis, and he doesn't have cancer. So his well score is definitely going to be low risk, so less than 4.5. Even if you said, oh, I'm not really sure, maybe PE is the most likely diagnosis, that's only gives him a 3. So he's actually still low risk. And so for low risk patients, you can use something called the PERC criteria, which is really just you're ruling out PE without any further investigations in a low risk patient. So Wells tells you if they're low risk or not. If it's less than 4.5, then they're low risk. For low risk patients, we look at the PERC criteria. So is their age less than 50? Is their heart rate less than 100? Are their SATs 95% or above? There's no hemoptysis, no estrogen use. And that point is important to ask. A lot of female patients won't, if you ask them their medications, I find they often don't tell you that they're on birth control. So important to ask. Any recent surgery, any prior DVT or PE, and then is there unilateral leg swelling that would make you think DVT? So he's low risk on Wells. He's actually negative on PERC. And so you can actually rule out a PE in this patient without doing any further testing. And then, if we had a 54-year-old patient who comes in with, sharp chest pain and shortness of breath, if you kind of apply the Wells criteria to him, if you look at the Wells criteria for him, doesn't have any signs or symptoms of a DVT, you might probably think PE is most likely. If his heart rate, is less than 100, he hasn't been immobilized, no previous PE or DVT. And then his doesn't have hemoptysis, doesn't have any active cancer. So again, he scores low risk on the Wells criteria, in that really he just has you think the PE might be most likely. So in him, you're then going to look at the PERC criteria. So you've decided he's Wells low risk. You look at the PERC criteria, and he's 54. So right away, you can't apply the PERC criteria for him. And so he's someone that needs to come out with further testing, at least to get a D-dimer, and then further testing if needed. Does that make sense to people? People often find this confusing. Lots of emerge docs still find this confusing. So again, not going to, diagnose PE in the nursing stations, but it's kind of nice for those patients that you can say, hey, you're actually low risk. We can use PERC and kind of perk you out, that we don't even have to work up PE anymore. So it kind of saves some transfers out. So typically PE, you're going to get a D-dimer. The patient will go on to get a CAT scan or a VQ scan, kind of depending on what's available and things like that. And typically these patients are treated with anticoagulation. How long they need to be on anticoagulation really depends on what we think the causes of the PE. So for some people, they'll get a PE after they had, major surgery or orthosurgery or pregnancy. And those patients tend to be on anticoagulation, for months to, a period of time, but they don't necessarily need lifelong anticoagulation. Whereas patients that are, high risk because they had a PE that wasn't caused by something like surgery, then those patients typically are on lifelong anticoagulation. Some patients, and it's really the patients who are quite sick, will end up going on to get thrombolytics. And typically it's the patient, who has an elevated trope with it, hypotensive, things like that. So again, not something that you're likely to be giving TNK for in the nursing station, just because we often don't have the diagnosis. Any questions about PE at all? Perfect. So kind of going to talk about thoracic dissection, which somebody had brought up. So certainly an important diagnosis. The spectrum that we see is actually kind of scary. We had a case not that long ago in Kingston of a patient with no chest pain that had a thoracic aortic dissection, which always makes all of us nervous because then you're worried about how many you've missed. But certainly it's something that we want to catch in the patients who present more classically. Some of the patients who obviously present in really atypical ways are just going to be super hard to diagnose. I tend to think about it again in the, patients certainly with that chest pain +1, or patients who tell me that, their chest pain started all of a sudden, it feels like it's tearing, radiating to the back. Like those are patients that for sure need imaging to rule out. Other things we talked about, so chest pain plus something, so they can have neurological symptoms just depending on whether they are dissecting essentially and down or whether they dissect up towards the head, and then they can get more neurologic symptoms. You can get hoarse voice from it as well. And then, patients with, limb pulse deficits or ischemia, motor weakness, things like that as well. And again, those kind of red flags are, it's very sudden onset, kind of terrible from the moment that it starts. And that classic ripping, tearing, sharp pain. And again, these are patients that you're not going to diagnose in the nursing station, but a really important diagnosis to think of because they need to not get TNK and they need to go to a center that has advanced imaging to be able to diagnose, and ideally a surgeon to be able to treat. So these patients, really the only definitive way to diagnose is a contrast scan. Either CT is typically what we do is a CT. There's some additional tests that you can do, certainly some of them in the nursing station that will help you maybe rule, or you can't rule them out based on that, but might bump up your suspicion for it up or down. But again, none of these can actually rule out a dissection. It's only a CT with contrast that can. So, do they have, part of your exam is going to be, do they have bilateral pulses that are equal? Do they have bilateral blood pressures that are equal? We start to think of it more when they have a differential of greater than 30. There is a percentage of the population, up to 20%, that have a 20% difference. So again, doesn't rule it in, not super helpful, but good to know. If you're doing blood work, so troponin can be elevated as well. Interestingly, your D-dimer, there's a few studies on that it can be elevated, again, not sensitive enough to rule it in or out with either troponin or D-dimer. If you have, chest x-rays where you are, there are certainly some signs that you can see on x-ray with a dissection, but patients can have a dissection in a totally normal chest x-ray. And again, POCUS, they're a bit of a difficult scan, but if anyone is there that has really good ultrasound skills, you can sometimes see some signs of dissection on that. So as you can see, it's a pretty hard workup, but important to kind of have that on your differential to think about, because this isn't a patient that you want to give thrombolytics to. And they could be a patient that comes in, with their chest pain and has a positive trope, and it's not an MI. Treatment for them, it really kind of just depends on the type of dissection. The goal really is to, give them good pain control, because what you're trying to do is minimize the stress on the wall of the aorta. And so every heartbeat kind of puts more stress, as you can imagine, on the aorta itself. So we try to lower their heart rate so it's not getting hit as hard every time. And we lower their blood pressure so that, again, there's just less kind of shearing stress on the wall. Again, may not be a patient that you're able to figure out enough to do in the nursing station. But if you have someone with classic symptoms, then you may actually, have enough or enough of a suspicion that you're looking at lowering their heart rate and their blood pressure. Any questions about any of that stuff? I'm going to pause for a minute here. And then we'll go into some cases. So please feel free to put any questions in the chat or unmute. I know it's hard in this format to kind of be super interactive, but feel free to kind of talk about it in your groups of if you're at work, just to get everyone's ideas. So case number 1, so there's a 64-year-old male with substernal chest pain that radiates to his arm, and it's been there for 45 minutes. He was sitting watching TV when the pain started, felt nauseous as well as diaphoretic. He has a history of hypertension, diabetes, and high cholesterol. And you do, your full head to toe exam. He has a heart rate of 62, normal sinus on the monitor. His blood pressure is 132 and 78. He has a rest rate of 16. His SATs are 97% on room air. On your exam, you find no murmur and no cardiac rub. His chest is clear, and he has no peripheral edema. And you've done an ECG. And this is your ECG. So just chat about it in your group about what you would do and what you think this is. If somebody is able to, if someone wants to unmute once your group has chatted, or just throw it in the chat. What do you think the diagnosis is? Oh, sorry, is it not showing up?
No, we can see it. We can
Okay,
see
perfect.
ECG. Yeah.
Perfect. So see a couple answers in there. Pericarditis would definitely be something to think about too. And someone has STEMI. And yeah, so this one is an anterior STEMI. And again, I don't assume that you're necessarily expected to diagnose this, but this one has a fair bit of ST elevation in the anterior leads. And also has some reciprocal, I don't know how easy it is to see actually on there. Does have some, in lead 3, some ST depression as well. So this patient, obviously, you would send off this ECG to the physician that you're chatting with. Treatment for this, so going to make sure that they have their aspirin as soon as they walk in. Whatever you have in terms of anticoagulation, Plavix or Ticagrelor or whatever you have in the nursing station. This is a patient, obviously, that you're going to want to get set up for transfer out as quickly as possible. And if you have access to TK, then this would be a person that, you'd want to go through the checklist and have a discussion with the physician about thrombolizing them. Not to forget to put this patient on the cardiac monitor and on defib pads. And then, looking at other adjuncts, so, nitro sprays or nitro infusion, morphine and fentanyl for pain. Any questions about that one? Does that one make sense? So case number 2. So it's a 64-year-old male who has some stroke symptoms. So the history really is the patient walked to the clinic and essentially kind of like collapsed as he arrived. He now seems a bit confused and he's not moving his right side. And so you're appropriately doing, your full history physical exam. And based on the, not moving his right side, you're leaning towards thinking that this is a stroke. The daughter comes in and tells you that the patient had a bit of chest pain earlier in the day, but had resolved before he came into the clinic. His past medical history, he's got hypertension, he's got diabetes, he has high cholesterol. You do kind of a head-to-toe exam. His heart rate's 92, normal sinus. His blood pressure is 172 on 88. His rests are 16. He's setting 95% on room air. Again, you do a focused exam. Doesn't have a murmur, doesn't have a rub. His chest sounds clear, doesn't have any peripheral edema. He does have kind of right leg and right arm weakness, which is what's leading you to think about kind of stroke symptoms. You do an ECG and it's normal sinus rhythm. There's no ST elevation or no ST depression. In your group, kind of maybe think through your differential of this one. And then feel free to either unmute or to pop it in the chat. Yep. So talking about stroke for sure, hemorrhagic or ischemic. Yeah, these symptoms would absolutely make you think that. Perfect. So this is actually a case that I had out of one of the nursing stations actually. And so that was kind of all this the story. It was not a lot of history, but currently has stroke symptoms. The reason why the patient actually came in or started going into the nursing station was that they had quite bad chest pain. And then kind of as they presented, started having these neurological symptoms. And so this patient actually had a aortic dissection. I love these. I can't read CTs. I'm not a radiologist, but I love these 3D recons, which I actually hadn't seen before for this. We often get them for like pelvic imaging or extremity imaging. And it's kind of cool. You can spin it like 360 degrees and actually look at the joint. But I hadn't seen this one before. So basically the kind of darker gold, I guess, orange, whatever it is, part here is really where there's the wall has torn away and there's a dissection with blood clot in there. And these are a bit of a hard diagnosis, right? His current symptoms are stroke symptoms. This is a patient that, you wouldn't necessarily, well, you definitely wouldn't want to thrombolize for a stroke. But these are, kind of hard cases to figure out. So that's why some of that history is really important. And just thinking again, like, is there something broader on my differential that I'm missing? Because you agreed he presents like a stroke when you see him. The fact that he had, this chest pain would be worth kind of diving into earlier in the day. The chest x-ray is a bit hard to see. Again, you can have totally normal chest x-rays with an aortic dissection, so it's not necessarily, it doesn't rule out at all. But he does have a bit of like a wide mediastinum here. And the kind of aortic knuckle that you tend to see looks distorted here. And so those are some of the things you can see on a chest x-ray of someone with dissection. All right, so case number 3. So you have a 64-year-old male, history of COPD. He's complaining of shortness of breath. He kind of walks up to the nursing station and says that his COPD is really flaring up and he thinks he needs some Ventolin nebs. So he felt acutely kind of short of breath this morning. He's been using his puffers without relief, which is why he thinks that he needs like nebulized Ventolin. He feels short of breath. He found it hard to kind of walk across the house from his bedroom to his bathroom. He has some pain in his chest, which he says is really worse when he's coughing or, when he's coughing a lot or when he's breathing hard. He has a history of COPD, hypertension, diabetes, and high cholesterol. So you do an exam on him. His heart rate's 99. His blood pressure is 132 on 78. His rests are 24, and he's satting 92% on room air. He's got no murmur and no rub. His chest is clear. He's got no peripheral edema. You do an ECG, and it's just kind of the sinus tach in at 99 to 100, and no ST changes. And he tells you, my COPD always flares up like this. They always just give me a couple of doses of steroids and some nebs, and I feel better. So maybe chat just for a minute or two in your groups. What's kind of your differential diagnosis for this patient? I'll open the chat again, just post them in the chat. Yep, so I'm seeing COPD exacerbation, yep. Versus PE, good. And again, so this patient's, one of the slightly tricky ones that didn't read the book. I think something to question yourself of is like, he swears it's a COPD exacerbation. He certainly has COPD exacerbations. His chest findings are totally clear. So that gives you something to kind of think and pause about. So it could be a PE. He could be a COPDer who actually has a fairly quiet chest now and isn't super wheezy just because he's actually that bad. But yeah, the fact that his chest is clear or quiet is a bit interesting. So you've done your exam and you're like, I don't know if you totally fit the picture of COPD exacerbation. So you ask them a bit more history, and the things that you're kind of mentally going through in your mind for, could this be a PE? So you're going to ask him some of the criteria, or things from Wells. So he tells you he has no leg pain, hasn't had any leg swelling. He's had no recent surgeries or immobilizations. He's never had a PE or a DVT. He hasn't been coughing up blood. No, not on cancer treatment. And so if you went through the Wells criteria, all of those things, he would be low risk. Again, even if you thought PE was most likely, he's going to have 3 points. So he's still low risk. And then in this patient, he's low risk, so you're going to put him through the PERC criteria. But there's two things that you can't apply, and you only need one. If any of these are not true, then you can't use PERC. So he is older than 50, so can't use it for him. And also his saturations rule him out. So this means that you can't use, you can't just say it's not a PE. So if you were to go on and do D-dimer testing, his D-dimer we'll say is like over 4,000. And so this patient now is someone who needs to get flown out to have a CT scan of his chest, essentially. And so I had this patient not all that long ago in the emergency department that, again, swore up and down that it was just a COPD exacerbation. But when I went to listen to him, his chest was perfectly clear. And I was like, this doesn't make sense. He actually had a history of a PE before, a long time ago. And for whatever reason, had just kind of been lost to follow up and hadn't been on anticoagulation, I think, for about 5 or 10 years. And so he had a quite large PE. So again, always just good to think about things, especially if your clinical exam doesn't fit the story or what you're thinking of. All right. Okay, last case. So a 64-year-old male with substernal chest pain, reading to his left arm for about 15 minutes. And the pain has now really resolved. So he was out for a walk, was basically walking right by the nursing station, was having this chest pain, and so came in. He has a history of diabetes, hypertension, and high cholesterol. On his exam, he's got a heart rate of 62, has a normal sinus rhythm. Blood pressure is 132, 178. His rests are 16. He's 97% on room air. You do your full head to toe. He doesn't have a murmur or reb. His chest is clear. He doesn't have any peripheral edema. And you do an ECG. And also you've sent off a trope. So your trope comes back at less than 10. I apologize. I know everyone uses different assays and different tests, but essentially his troponin comes back negative. And this is his ECG. I'll give everybody a minute to just look at it. So his ECG is like, that's a normal sinus ECG. There's no tricks to it. There's no ST changes or anything. And basically he'd come in, you did the ECG, you drew the troponin right as he presented. So kind of chat now about what's your diagnosis, what's your next steps? Is there anything else you want to do? Perfect. Seeing some quick answers in the chat. Coronary spasm, yep, definitely could be. ACS angina, rule out trope times 2. So yeah, that's kind of the trick with this one, is that you did the troponin so quickly after the chest pain started that it actually hasn't had time to rise. And that's why, important to do double tropes in a patient to rule out ACS. Again, it's going to depend on what assays you have as to how long you're repeating the troponin. The kind of old, not high sensitive ones, we used to do 6 hours. The kind of newer high sensitivity ones, there is varying evidence on, so people will do something between 1 and 3 hours. Yeah, and I see people saying the same thing. So you're going to observe and repeat the trope. Perfect. So we'll say you have a high sensitivity troponin and you repeat it in 3 hours. So his initial trope is less than 10. His second trope is 400. His ECG, I'll give everybody a second to look there. Mira, to answer your question, I assume you mean the troponin Q 4 hours. Again, it really just depends on the troponin assay that you have. And obviously, and like there's a bit of variability in terms of like physician practice. But 4 hours would be reasonable. The assay that I have access to is actually one of the quite high sensitivity ones. So I typically repeat it in 3 hours with a patient. Again, there's a bit of variability in range of time. I think the important thing is certainly like repeating the trope on this patient because it'll be negative initially. So one trope really can't rule out chest pain, with a few rare exceptions of they've had chest pain, for the last 12 hours and it is exactly the same. It's never gone away. It's never kind of waxed and waned. Then they've had it long enough that if it is causing any myocardial injury, that it'll be raised. Perfect. And so I see in the chat here, yeah, NSTEMI based on the trope. And agree, need to get the patient out for transfer and angiogram. And again, this is a patient that in the meantime, while you're arranging transfer, you're going to give an antiplatelet and an anticoagulation too. All right. I will stop sharing so I can see people. Perfect. Any questions? And And again, thanks for popping things in the chat. I know it's a hard format for everybody to unmute, but
A very quiet group.
it's okay.
Any comments, questions, anything about the presentation, about the services you provide, you want to share?
Good morning. This is Mira. Thank you for the presentation. Good timing. We actually recently just had a PE that was very difficult to diagnose. We had an older lady that came to the clinic with abdominal pain, epigastric pain, mild shortness of breath with mild desaturation, and she was COPD as well. Lots of comorbidities. She had some, I think, some fracture previously. She was sitting at home on a chair for a long time. The lungs were kind of clear. There was maybe some crackles. She was diabetic too, wasn't eating. She was treated for hypoglycemia, interestingly enough. And then after like 6 hours, she was sent back home. Improved, and then about, I think within like 4 days she came back. At this point she had same presentation but much worse. Same with the epigastric pain, and very difficult to figure out, and maybe minimal crackles on the right lobe. We kind of did troponin was negative. The bottom line is we end up medevacing her, and she did have massive PEs because she was sitting on a chair all the time. But it was such a typical presentation, and it was very hard to figure out. We did the chest x-ray. Chest x-ray showed something that I've seen on some lower lobe, but it was really non-conclusive. And wow, one of those very hard PEs to diagnose.
Yeah, that's super hard, right? And as patients are kind of getting sicker and more comorbidities, it's, it just gets harder and harder to do things. So yeah, you're not like, we all miss, even with the best access to the best imaging and all of that stuff. Some of these things are just easy to miss in patients that don't present classically. So
Yeah, and thank you. Thanks for your presentation.
no problem.
Okay, any final questions? Okay, well, thank you very much, Dr. Pritchard, for your time. And thank you, everybody, for giving us an hour on this Thursday morning. Have a great day, everybody.
Thanks, everyone. Have a good day.